morning, everyone, and thank you for joining this session. My name is Arya Babul, and I am a biomedical sciences student at West Career and Technical Academy in Las Vegas, and I serve as the president of the Society for Awareness of Neglected Diseases. It's a genuine privilege to be presenting at this conference. Today, I'd like to walk you through a topic that sits at the intersection of immunology, clinical therapeutics, and unmet patient need, navigating JAK inhibitor therapy in alopecia areata. Let's begin with a brief orientation. Alopecia areata is a chronic autoimmune form of non-scarring hair loss that presents in well-defined patches, most commonly on the scalp, but also on the eyebrows, eyelashes, beard, and other body sites. Clinically, we recognize three principal variants: patchy alopecia areata, which is by far the most common, alopecia totalis, where the entire scalp is affected, and alopecia universalis, characterized by complete loss of all body hair. This figure shows select patterns of hair loss in alopecia areata, including eyebrow loss in panel A, extensive patchy hair loss in panel B, and alopecia universalis in panel C. Let's first look at the mechanism driving this process, because understanding it is essential to appreciating why JAK inhibitors have become such a rational therapeutic target. This figure illustrates the immunologic cascade at the heart of alopecia areata. Under normal circumstances, the hair follicle enjoys a state of immune privilege. In alopecia areata, that privilege collapses. The follicle appears foreign to the adaptive immune system, and what follows is a targeted assault. CD8 positive cytotoxic T cells infiltrate the peribulbar region, accompanied by a surge of pro-inflammatory cytokines, most notably interferon gamma and interleukin-15. Clinically, this manifests as the sudden, often dramatic hair loss that defines the disease. Now, what's critical for our discussion today is that both interferon gamma and interleukin-15 signal through the JAK-STAT pathway, specifically through JAK1 and JAK2 for interferon gamma, and JAK1 and JAK3 for interleukin-15. This makes the JAK-STAT pathway a compelling therapeutic target. To quantify hair loss objectively, we rely on the Severity of Alopecia Tool, or SALT score, which is the standard metric used across clinical trials. As you can see on the slide, it ranges from 0, no hair loss, through mild, moderate, severe, and very severe categories. A SALT score of 50% or higher denotes severe disease, and this threshold is clinically important because it's associated with substantial physical, psychological, and economic burden. It's also the severity range where JAK inhibitors are indicated. This slide lays out the therapeutic landscape, and the key message is this: until very recently, every treatment option for alopecia areata was used without FDA approval, in other words, off-label. Corticosteroids, topical, intralesional, and systemic, have long been the backbone of management. Topical corticosteroids remain first line, either as monotherapy or in combination, while intralesional injections are frequently employed with adults with acute or chronic disease and for solitary patches. Beyond steroids, clinicians have reached for other treatments listed here. The problem, of course, is that none of these agents were approved for alopecia areata, and the evidence supporting them is largely limited to case series and small studies. That changed with the arrival of oral Janus kinase inhibitors, or JAK inhibitors. the only class of drugs to receive regulatory approval for this indication, and the focus of the rest of this presentation. Let's take a closer look. JAK inhibitors have truly revolutionized the treatment of severe alopecia areata. They represent the only approved therapeutic class for this disease, and they've demonstrated outstanding efficacy in clinical trials. Three agents are currently approved: baricitinib, administered once daily in adults and available across all major markets; ritlecitinib, also once daily, with approval for both adolescents and adults in all major markets; and deroxolitinib, dosed twice daily in adults and currently approved in the United States. Each of these drugs targets the JAK-STAT signaling axis, but they do so with different selectivity profiles. This brings us to a key question: how do these agents differ mechanistically? This table is worth spending a moment on because the selectivity profiles of these three agents are quite distinct. Baricitinib and deroxolitinib are both primarily JAK1 and JAK2 selective inhibitors. By blocking JAK1 and JAK2, they broadly suppress cytokine signaling, including the interferon gamma pathway that drives follicular immune attack. Ritlecitinib, on the other hand, takes an entirely different approach. It is highly selective for JAK3 and TEC family kinases, with minimal activity against JAK1 or JAK2. This means ritlecitinib more directly targets the T-cell receptor signaling and IL-15 pathways that mediate cytotoxic lymphocyte activation in alopecia areata. These mechanistic differences aren't merely academic, they have real implications for both efficacy profiles and adverse event spectra. A JAK1, JAK2 inhibitor will modulate a broader range of downstream cytokines compared to a JAK3 TEC selective agent, which may translate into differences in respond rates and tolerability. With that framework in place, let's look at what the clinical data actually shows. The headline here is encouraging. All three approved JAK inhibitors demonstrate significant efficacy in promoting hair regrowth, and not just on the scalp, but also eyebrow and eyelash hair, which is particularly meaningful to patients. Treatment effects are typically observed by 24 weeks, with significant further improvement continuing out to 52 weeks. This time-dependent gain is an important counseling point for patients, because early non-responders may still achieve meaningful growth with continued therapy. However, the story is not entirely straightforward, and that leads us to a frank discussion of efficacy limitations. This image shows representative clinical cases of patients with early, gradual, and late responses after treatment with baricitinib. Similar patterns are observed with ritlecitinib and deroxolitinib. This slide is one I think every clinician prescribing JAK inhibitors should internalize. Despite the enthusiasm surrounding these agents, only about 40 to 45% of patients achieve a SALT score of 20 or less, which is the threshold most patients and clinicians consider a satisfactory cosmetic outcome. That means more than half of treated patients will have a suboptimal response. There are additional concerns. After discontinuation, the relapse rates are sobering. Approximately 50% relapse within 6 months, and up to 80% relapse by 3 years. Perhaps more troubling, retreatment after relapse yields diminished responses, with efficacy reductions ranging from 13% to 37% compared to initial treatment. We also know that patients with longer disease duration tend to respond less favorably, likely reflecting more entrenched immunologic dysregulation. One encouraging nuance, though, is that failure on one JAK inhibitor does not reliably predict failure on another, which makes sense given their differing selectivity profiles. This underscores the importance of having multiple agents available. Here's the problem. All three JAK inhibitors were approved based on placebo-controlled studies. No head-to-head trials exist comparing one agent directly against another. Conducting such studies would require large, multinational, multi-center, non-inferiority studies. And frankly, there's very little commercial incentive for any single pharmaceutical company to fund a trial that might demonstrate its product is inferior to a competitor's. So, how do we generate comparative evidence in the absence of direct data? The answer is network meta-analysis, or NMA. NMAs leverage the shared placebo comparator across studies to construct indirect comparisons between active treatments. It's an established methodology endorsed by health technology assessment bodies worldwide, and it was the approach we adopted for our study. Our study, published in the Journal of Dermatology in October of 2025, was a Prospero-registered systematic review and network meta-analysis. We conducted a comprehensive literature search to identify randomized controlled trials evaluating the three US-approved JAK inhibitors, baricitinib at 2 milligrams and 4 milligrams once daily, ritlecitinib at 50 milligrams once daily, and deroxylitinib at 8 milligrams twice daily. We employed Bayesian NMA and population-adjusted indirect comparison methods. Our primary outcomes were the proportions of patients achieving SALT 10% or less and SALT 20% or less at week 24, thresholds that would represent near complete and clinically meaningful regrowth, respectively. Let me walk you through what we found. Our analysis incorporated data from 7 randomized controlled trials, enrolling a total of over 4,500 participants, a robust dataset for an NMA in this therapeutic area. The first and most important finding is that all JAK inhibitors were statistically superior to placebo, which reaffirms their therapeutic value. When we compared agents against each other, deroxylitinib at 8 milligrams twice daily consistently ranked as the most effective intervention, achieving the highest probability of response across both SALT endpoints. Baricitinib showed significant improvement at both the 2 and 4 milligram dose, with a clear dose-response relationship. Ritlecitinib at 50 milligrams demonstrated favorable outcomes but did not outperform deroxylitinib in our indirect comparisons. Importantly, while differences between deroxylitinib and ritlecitinib favored deroxylitinib, they did not always achieve statistical significance, a nuance that is critical when interpreting indirect evidence. To quantify these rankings more precisely, we generated SUPRA values. SUPRA, the surface under the cumulative ranking curve, is a metric that distills the relative ranking of each treatment in a network meta-analysis into a single probability score. A higher SUPRA value indicates a greater likelihood of being the best performing intervention. As you can see in this figure, deroxylitinib 8 milligrams achieved the highest SUPRA rankings for both SALT 10% or less and SALT 20% or less, followed by baricitinib 4 milligrams, baricitinib 2 milligrams, and ritlecitinib 50 milligrams. These rankings provide a useful framework for clinicians considering treatment selection, though they must be interpreted within the limitations of indirect comparison. And that's exactly where I'd like to close, with a balanced discussion of what these findings mean in practice. Let me bring this all together. JAK inhibitors represent a genuine paradigm shift in the treatment of alopecia areata. For the first time, we have approved therapies with demonstrated efficacy in severe disease, a population that was historically left with off-label options and often limited hope. Our network meta-analysis suggests that deoxynivalenib may offer improved clinical outcomes relative to the other approved agents, achieving the highest efficacy rankings across key endpoints. However, and I want to be very clear about this, these comparisons are indirect. They are derived from separate trials with different patient populations, enrollment criteria, and study designs. The possibility of residual confounding cannot be eliminated, and we should be cautious about drawing definitive conclusions in the absence of head-to-head data. That said, in the current evidence landscape, our analysis provides something valuable, a comparative framework to help guide clinical decision-making. When a clinician is choosing between 3 approved agents for a patient sitting in front of them, even indirect comparative data is better than no comparative data at all. I would also emphasize that treatment selection in practice will depend on far more than efficacy rankings alone. Safety profiles, dosing convenience, patient age, insurance coverage, and individual patient preferences all factor into shared decision-making. Ultimately, what this field needs are well-designed, adequately powered, head-to-head trials. Until those exist, network meta-analyses like ours serve as an important bridge, imperfect but useful. Before I close, I want to warmly acknowledge the collaborators who made this work possible. Thank you so much for your time and attention.
Good morning, everyone. My name is Melanie Elisa Ayala Gonzalez. I'm from La Paz, Bolivia. I'm happy to be here today, even if via Zoom. And today I'm going to present cutaneous rosai dormant disease. Our patient was a 51 years old woman with hypothyroidism and the trait. She referred lesion, nodular lesion in left temporal region. And according to the clinical history, she said that the lesion increased in size after manipulation. Do go to the dermatology clinic after 1 month. We can see this lesion, nodular lesion, not painful to the touch, and it's a firm and violet lashes and adherent to deep planes. This is the dermatoscopy. We can see a homogeneous color and the size 1.5 to 2 centimeters. The laboratory studies no revelate major abnormality. However, we can see this ultrasound, and then we can see a subdermal epicoic encapsulate lesion, a vascular, and the conclusion was epidermal cysts. We have this differential diagnosis where lymphocytoma cutis, cutaneous B-cell lymphoma, and cutaneous metastasis. We remove all the lesion
Sorry
and
for the interruption, Dr. Melanie. Your slides are not
yes,
moving. Can you please change the slides? It's in the first slide. Yes, now we can see.
okay. Now,
Yeah.
can you see? Okay. This is the biopsy. We can see epidermis and in this part of the lesion This is the dermis, and we can see an infiltrate with lymphocytes and histiocytes, and one phenomenon of erysipelosis, and this is the immunohistochemistry, positive for S100 and positive for CD68. With all of that, we have this diagnosis. I think that you don't see the previous lesion, but it was the woman. It was a nodular firm node, not painful to the touch, the eyelashes, and this was the dermatoscopy. The color was homogeneous. Okay, this is the patient after the treatment. We remove all the lesion, and this is the patient 3 months after. What about cutaneous rosai dormant disease? Cutaneous rosai dormant disease is a non-Langerhans cells histiocytosis. The prevalence is low, 1 in 200 people, and the form cutaneous is extremely rare. Why? The type of disease. What about the pathogen? We can see that many viruses like cytomegalovirus, herpes simplex virus, HIV, and other types of virus can involve this type of lesions or rosacea dormant disease, and can be a reactive process. However, we can see in this slide that mutations in MAPK genes can be cause the disease, and the process can be not just reactive, can be neoplastic. The clinical manifestations we can see in these patients nodules, plaques, or biological lesions in the face, in the trunks, on the extremities. And what about the other manifestations? Not all the patients present these types of manifestations. However, we can see that patients who can present manifestations in heart, in central nervous systems, with headache, for example, in lungs, with cough, and others. And we can see these lesions, we can see these types of lesions can be nodular, violations, plaques. In this slide, we can see that there are can be one or two, but in this other slide, we can see that can be in many regions. Can be in plaques too, and these papers is important because show that rosacea dormant disease can appear to other scars. For example, keloids can be associated with lupus, uveitis, lymphoma, and others. We don't have many reports medical. This is one report, one review report since 1919, and we can see um, 72 patients with this entity. About the treatment, there isn't an universal treatment for this disease. However, surgical resection is the treatment of choice for small lesions. Nevertheless, recurrence is 20 to 50%. We can use radiotherapy, chemotherapy, rituximab, steroids, and others. These recommendations for the diagnosis and clinical management for rosacea dormant disease say that the most effective treatment for unifocal cutaneous rosacea dormant disease is the surgical excision, like our patients. And we can see that in this slide uh, with, with complete response in these patients without severe adverse effects or side effects. About the diagnosis, it's important It's essential the biopsy, the clinical and the histological lesion, and if our patients need an ultrasound or organic specific test or imaging or, for example, complete blood count, we have to do, but the biopsy is the most important. Why? Because we have a lot of differential diagnoses in the skin, like lymphocytoma, cutis, Kaposi sarcoma, lymphoma B, histiocytosis, and skin metastasis. In conclusion, rosai dorman disease limits to the skin is a rare entity, like our patients, and genetic mutations just, suggesting that this disease may be considered neoplastic and not just reactive a virus, for example, herpes virus, cytomegalovirus, etc. And we contribute a new case to the rosai dorman disease, including clinical, dermatoscopy, histological findings. Thank you so much.
Thank you for your invitation. I am delighted to participate and share our dermoscopic study from the Dermatology Department of Ibn Sina Hospital of Rabat in Morocco. Dermoscopy of rosacea, a comparative study between dark and light phototypes. Rosacea is a chronic inflammatory skin condition that manifests with various signs, including erythema, papules, pustules, telangiectasias that mostly affects the cheeks, the chin, and the central forehead. It's a continuous spectrum, including the erythema to telangiectatic subtype, the papulopustular, and phema. In the literature, this condition is uncommonly described in patients with dark phototypes. This study aimed to describe dermoscopic features of rosacea in dark phototypes and also compare them with these characteristics in light phototypes. We will also emphasize the major role of the dermoscope in increasing diagnosis accuracy of rosacea in dark skin patients in order to prescribe the appropriate treatment. It's a cross-sectional, descriptive, and analytic study including dark and fair skin patients with a clinical diagnosis of rosacea confirmed or not by histopathology. This study was conducted over a period of 4 years, and data was entered using Excel software and analyzed using Jamovi version 2.3. 206 patients were included in the study. The mean age was 45.8 years old, and the majority of the population studied were women with a sex ratio of 6.63. More than 2/3 of the studied population had a dark phototype. We compared to this study the characteristics of rosacea in dark and light phototypes. In both of them, women were predominant, and as you can see here, the mean age was significantly higher in dark phototypes. Concerning the subtypes, 84% of dark phototypes had the erythema to telangiectatic rosacea, while 52% in light phototypes. 12% of dark phototypes had a papulopustular subtype, and up to 45% of light phototypes. We found phema in only 4% of patients with skin of color and 3% of light phototypes. There was a significant association between the phototype and the erythema to telangiectatic and the papulopustular subtypes. In fact, the erythema to telangiectatic subtype was more frequent in dark phototypes, and the papulopustular was more frequent in light phototypes. 39% of dark phototypes had no visible erythema clinically, but the dermoscopy revealed vascular patterns with linear branched and curved vessels and also pigmented areas. So what about dermoscopy? What did we find? We found that pigmented areas were predominant in dark phototypes, and orange structureless areas and crusts were predominantly seen in light phototypes. In this dermoscopic image of granulomatous rosacea, we have a vascular patterns with linear branched vessel forming polygons, an erythematous background, and multiple orange structureless areas distributed focally. The second image shows crusts and pustules with also a vascular pattern and erythema. We found a statistically significant association between the phototype and pigmented areas, orange structureless areas, and crusts. On the other hand, we didn't find a statistically significant association between the phototype and the following dermoscopic signs: polygonal vessels, linear branched and curved vessels in a reticular distribution, also hairpin vessels, dotted vessels, comma-like vessels, as shown here in the image. So here we have hairpin vessels, dotted ones, and comma-like vessels. Perifollicular pigmentation, and scales as well. Demodex scales were seen as white protruding materials projecting out of hair follicles. Concerning pustules, 13.8% of dark phototypes presented pustules non-visible clinically with a significant association. In female, we found follicular yellow clots, rosettes, and vascular patterns. So our study is the first to compare dermoscopy between dark and light phototypes. We found that dark skin patients were older, that pigmented areas and pustules were significantly associated with dark phototypes. However, vascular patterns were not associated to the skin type. Very few articles have described rosacea in dark skin patients. The exact pathogenesis is still unclear. A genetic component, alterations in the immune system, UV exposure, and neurological dysfunction all play a role. The pathogenesis primarily involves skin barrier and vascular alterations, such as persistent vasodilatation and abnormal vasomotor response to various stimuli, leading to more superficial blood vessels seen by dermoscopy. So dermoscopy helps in the visualization and the description of these vessels, scales, and color variation that may be difficult to recognize with the naked eye. Clinically, in dark phototypes, erythema and pustules are difficult to be seen, leading to diagnosis difficulties. Dermoscopy has gained popularity in those patients. In fact, dermoscopic patterns may significantly vary because we have, first of all, a darker background that may change some dermoscopic features. We also have some reaction patterns that are more common in dark skin. For example, a higher tendency for pigment lability, which is responsible for a higher prevalence of pigmented areas. We also have more follicular and sclerotic reaction described in the literature. Articles on dark phototypes included a very few number of patients, 1 for Shepshub et al. And 11 for Erichetti et al. Larger studies were mainly conducted on light phototypes. Our study has the largest number of patients with both phototypes and including all of the subtypes. In all studies, vascular patterns were predominant, Some particularities were seen in dark phototype, such as peripheral pigmentation in areata and all, and pigmented areas in our study. We had a large number of patients, including both phototypes, with significant results. However, our study is monocentric. Some patients have already started the treatment, and the follow-up is still going on. In conclusion, rosacea in dark phototypes is common in our context and probably underdiagnosed. Our study showed a remarkable variability between phototypes as we previously described. Dermoscopy allows us to visualize vessels, facilitates the recognition of the clinical subtypes in order to guide the treatments. Thank you for your attention, and if you want to learn more about our study, we have published it in the JAD International, so you can check it out. It's an open access, and I want to thank you again for the invitation. If you have any question, I can answer, and this is my email for more information. Thank you.